So we were discussing the third question. So the question says that on the third day after acute MI, right? On the third day, remember this is very important. On the third day after myocardial infarction, right? What has happened? There is a dull ache behind the breastbone that can be reduced by bending forward. Okay, and blood pressure is 140 by 180, which is really high, and heart sounds are dull. Real ECG, you can see the atrial fib with frequency of ventricular contractions at the rate of 110. Pathological Q wave, keep in mind that you will find pathology in the normal ECG. It is very difficult to find the Q wave, but if you are finding prominent Q waves in the ECG, it means that either the patient is hypokalemic. Even in case of hypokalemia, you will find pathological Q waves, or if there is any sort of infarction, even in the infarcted patient also, any kind of infarction in the heart. So even in case of infarction also, you will find this pathological Q waves. Okay, so what I was telling, that pathological U wave is found in case of hypokalemia, but whereas pathological Q wave, basically you don't see it in an ECG, but if you see, then pathological Q wave is mainly because of infarction. Whenever there is any dead tissue or damaged tissue due to ischemia, if you find it in the heart, then there you will find the pathological U wave. Okay, but anyways, that is not important for our discussion now. What is important is the question. What is the question telling? There is also ST segment elevation, right? There is also ST segment elevation. The patient refused from thrombolysis. What is the most probable diagnosis? You know the answer, it is acute pericarditis. But why it is acute pericarditis? Look here. When the patient had MI, for example, if I have MI, after 3 to 7 days, if I develop chest pain, after 3 to 7 days after MI, if I develop chest pain, it is most commonly because of acute pericarditis. Okay, now in other scenario, I had MI today, and after 3 weeks to several months, after that if I develop the chest pain, then it will be because of Dressler's syndrome. So Dressler syndrome does not develop in an acute condition, I mean does not develop immediately after post MI. Okay, it develops only after, it takes around 3 weeks to months to develop. But if it develops immediately, if you have chest pain immediately, then it is not Dressler's, it is acute pericarditis. Now let us discuss few important things about acute pericarditis. Now, as you know, we have a pericardium or the covering around the heart, right? If there is any inflammation of the pericardium, we call it as pericarditis, right? Now, when I tell pericarditis, damage is only to the pericardium, not the heart. So when damage is not to the heart, then the hemodynamics of the heart won't change. Okay, but anyways, we'll be discussing that one by one. So see here, first thing is to rule out it is to diagnose that, to confirm the case it has a acute pericarditis. First thing is, I told you, after MI, after 3 to 7 days after MI, if patient has chest pain, then you can think it as a acute pericarditis. Second thing is, patient will have chest pain at rest. Okay, patient will have chest pain at rest. Second thing is, problem is to the pericardium, not to the heart. So the heart sounds will be normal. I mean S1 sound and S2 sound is absolutely normal in this patient. And third important thing is, patient won't have pulmonary edema here because there is no problem with the heart. Again, I am telling you, there is no problem with the heart. There is only problem or inflammation with the pericardium. So pulmonary edema is absent here. Now why I told specifically pulmonary edema? Because see here, the first point which I told is patient is having chest pain at rest. Even in myocardial infarction also, you see chest pain at rest condition. Now how do you differentiate MI with acute pericarditis? It is, in myocardial infarction, not only chest pain at rest, along with this the patient will have pulmonary edema component. Okay, but in acute pericarditis there will only be chest pain at rest without pulmonary edema. So this is a differentiating factor. Okay, and in acute pericarditis, as the heart is normal, so patients S1 and S2 sounds will be normal. Coming to MI, as you know, most common MI is anterior wall MI, right? Most common MI is anterior wall MI. So in this patient, as the left ventricle doesn't function properly, so when the left ventricle fails to function, so patient will have loud S1 sound and patient will have narrow split S2 sound. I hope you know what is loud S1 and narrow split S2, right? Now, third important thing is, as you can see here, when you look at the ECG, here also you will have ST elevation, and even here also you will have ST elevation. But when you look at the ECG clearly, the ST elevation here is different. This is your P wave, Q, R. You see? Now look at the ECG here. P wave, Q, R. Now look here that in acute pericarditis there is ST elevation, but this ST elevation is convex or concave? It is convex. Okay, but where you see in MI, in case of MI, when you see the ST elevation, just a second, I'm really sorry, I just made a mistake here, so let me correct it. Yeah, I'm sorry. Now look here, in MI, in case of myocardial infarction, when you look at the ST elevation is convex. But when you look at acute pericarditis, here also you have ST elevation, but the ST elevation here is concave, right? And a T wave inversion. Here also you have the T wave inversion, that is another thing. But the ST elevation in acute pericarditis and MI is different. One is convex and another one is concave. Okay, so this is how you differentiate acute pericarditis with myocardial infarction. And another thing is, as you already told here, there is ST elevation. We already discussed two different types of ST elevation. First of all, what are the cases where do you find ST elevation? ST elevation, one thing you are sure, you know, it is acute pericarditis. Second thing, you also know it is MI. And third thing is left ventricular aneurysm. So these are the three cases where you find ST elevation, right? So hope you understood why the answer is acute pericarditis now. Okay, now coming to the second option, look at the second option. The second option says pulmonary embolism. Now what is pulmonary embolism? What is the most common cause of pulmonary embolism? The most common cause of pulmonary embolism is deep vein thrombosis. Okay, so let me put a picture of deep vein thrombosis over here so that it would be really easy for you to understand. Yeah, so let me take this picture out. Yeah, now look at this picture here. Look at this picture. Now in this picture, this green color valves which you can see here, this green color things, these are the valves which are present in the veins. For example, these are the valves which are responsible to pump the blood from the lower extremities, from the lower part of your body into your right atrium. For example, if these valves are dysfunctional, can the blood be ascended up, or can the blood be squeezed up or pumped up? No. So what will happen? The blood stays there, causing a big thrombus here. You see, this is a thrombus, and what will happen to this thrombus? This thrombus will ascend up all the way like this. This thrombus will ascend up and finally enter into your right atrium. From there it will go back into your right ventricle, and from there this thrombus enters into your pulmonary artery and obstructs your pulmonary artery. So when this thrombus obstructs your pulmonary artery, do you think that the patient can breathe normally? No, the patient cannot breathe. So in case of pulmonary embolism, the patient will have sudden, very sudden onset of dyspnea. Not only sudden onset of dyspnea, patient will also have sudden onset of chest pain. Keep in mind that in the question, if they ask you, the patient is having sudden onset of chest pain, only in two conditions you will find sudden onset of chest pain. Sudden onset of chest pain you will see in case of pulmonary embolism, and you will see in case of pneumothorax. Right. Second important thing is, as I told you, what is the most common cause? Most common cause is deep vein thrombosis. So here in the question, they haven't given any history of deep vein thrombosis. So pulmonary embolism will not be the answer. At the same time, in the question, they haven't given that the patient is having sudden onset of chest pain and all. So pulmonary embolism will not be the answer. Okay. Not only chest pain, patient will also have hemoptysis. And in the question, they haven't given anything about hemoptysis as well. Right. Another important thing is, how do you diagnose this case? You diagnose this case by using CT angiography. This is the gold standard. Gold standard is CT angiography, right? Where there you can find where is the clot. Maybe is it in the right or in the left pulmonary artery. Now, how do you treat the patient? Of course, you have a clot there, so you have to remove the clot. You do embolectomy. Or you can also give vitamin K to the patient, or you can give varofin to the patient. Vitamin K or varofin to the patient, right? So this is the entire discussion regarding your pulmonary embolism, and now I think you understood why the answer is not pulmonary embolism. Now coming to option C, what is dissecting aortic aneurysm? Look here, let me erase this picture. Yeah. Now what is this dissecting aneurysm? Dissecting aortic aneurysm is, for example, you see that this is your blood vessel, right? This is your blood vessel. Now surrounding this blood vessel, basically the blood vessel is having three layers, right? Tunica intima, tunica media, and tunica externa. So this red color layer which I drew here is tunica intima. Now the next green color layer which I am drawing here, this is called as tunica media, for example. And let me highlight it a little bit. So let us think that this is tunica media, okay, on either sides. This is tunica media, where you basically have your muscle layer, and outermost layer you have tunica externa. So this is your tunica externa, right? So this is your tunica externa, and as I already told you, this is your tunica media, right? So this is your entire blood vessel. Now look, sometimes it might happen like this, that when there is high pressure within the artery, for example, let us think the patient is suffering from hypertension. severe hypertension. When the patient is having severe hypertension, obviously there will be excess amount of pressure. When there is such excess amount of pressure, of course the blood here will be exerting a lot of pressure on the valves here. The blood will be exerting a lot of pressure on the valves. So the pressure sometimes will become too much high that the tunica intima will tear. Tunica media also sometimes might tear. So when the tunica intima will tear, what will happen now? Yeah, when tunica intima will tear, the blood will dissect on opposite sides. You see here, the blood is dissecting between the layers. It is dividing, it is dissecting, it is cutting down and going, right? So this is called as aortic dissection. This is called as dissection of the blood. So as a result, what will happen? As a result, what will happen here? As the blood has been dissected, the layers surrounding that, there will be an aneurysm that is formed surrounding the layers. Okay, so this aneurysm which has been formed here, of course here there is no doubt that here you have a lot of blood, right? Here you have a lot of blood. Clear? So there is an aneurysm that is formed because of dissection of the blood here, right? So you call it as dissecting aneurysm. Basically there are two types of dissecting aneurysm. One is called as Stanford A, another one is called as Stanford B. Stanford A is if the dissecting aneurysm happens only in the ascending aorta, it is Stanford A. If it happens in the descending aorta, it is Stanford B, right? I'm sure that you know we have arch of aorta like this, ascending aorta, and you have an aorta that is descending down. If it happens here somewhere, then it is Stanford A. If it happens here, it is Stanford B, right? So this is all about the discussion of your dissecting aortic aneurysm. Now why we didn't, and by the way, another important thing which I want to highlight is, what is the most common cause of dissecting aneurysm? It is hypertension, right? Now how will the patient present here? Patient will be having acute chest pain, severe acute chest pain, and this chest pain will be radiating to the back. Where to the back? Between your scapula, between your scapulas. Did the patient complain of such acute chest pain radiating to the scapula? No. Patient complained of dull pain behind his breastbone or dull pain in the chest. So this is not an option. As I already told you, if you see a question with acute chest pain, then you need to think of two things. One can be pulmonary embolism and another can be spontaneous pneumothorax. Now in this patient with dissecting aortic aneurysm also, there is acute chest pain. Now I can think of spontaneous pneumothorax, I can think of pulmonary embolism, but most commonly I can think of spontaneous pneumothorax. So for that, to rule out spontaneous pneumothorax, any type of pneumothorax, what is the first thing I do? I do a CXR, chest X-ray. In the chest X-ray, I'll get to know whether the patient has spontaneous pneumothorax or no. So I'll do chest X-ray to rule out pneumothorax. After that, what is a gold standard? Gold standard for dissecting aneurysm is CTA angiography. Here I can find very clearly where the aneurysm has occurred. Okay, coming to the treatment and all, you need to give you need to do the vascular surgery for the patient. So anyways, so this is just a brief information which I've given on the aortic aneurysm. So I think this is enough. Coming to the Dressler syndrome, I already told you, if the option has to be Dressler syndrome, then the time period should be more than 3 weeks to months, but here the time period is just third day. Coming to Tight syndrome is not that important, but remember one point, that in Tight syndrome, your coastal arches or the ribs, coastal cartilages, they are inflamed, which has nothing to do with this setting of the question, which has nothing to do with pathological give, which has nothing to do with ST segment raising. So I hope you understood question number 3. Let's take a break and then switch on for question number 4.